Today we're going to review introductory arterial line assessment and management, including blood specimen collection. Arterial access and lines have a variety of uses, including cardiac and peripheral interventions, IABP or invasive arterial blood pressure monitoring. They can be placed in any artery with a palpable pulse except for the carotid artery. This includes brachial, radial, femoral, popliteal, posterior tibial, and dorsalis pedis. You'll notice that we have an asterisk by the radial and femoral access sites. These two are the most common, especially in critical care for IABP monitoring. First, let's collectively look at all the pieces of an arterial line setup. Here we're looking at a femoral access site. You'll notice the X on top of the tegaderm, and that is our simulated access site. When you feel the tubing, you will notice that it is very rigid. It maintains high pressure within the line in order to get accurate readings of the patient's blood pressure. Just adjacent to the access site, you will see a device called a three-way stopcock. This useful device adds an access port to a 2-lumen line. You will see these used in a variety of ways in healthcare, especially in critical care, but today we are going to be using the stopcock in order to retrieve a blood specimen. When looking at the device, you will notice a lever. The lever has letters on it indicating off. Whichever way that lever is pointing means it is off. When the lever is pointed towards the access site, we consider that off to the patient, meaning that there is a lumen open on the open port that you see capped here and the transducer set, which we will get to in a minute. Alternatively, when the lever is pointed away from the patient's site up the transducer line, we consider that off to the line. Whenever it is in the neutral or capped position, we call that off to the air. While we are monitoring the patient, all stopcocks need to be in the off to the air position. Continuing to move up the setup, you will see an additional stopcock that is also a three-way stopcock just below a device that we call a transducer. The transducer has an electronic cord that resembles a phone cord. This sends signals to the patient monitor while we were monitoring the patient's vital signs. The transducer itself is what you will see clipped in this large clothespin looking item. Above that, you will see a squeeze trigger flush mechanism, which I will review soon. The rigid high pressure tubing that we noted below the level of the transducer is not used above the level of the transducer. This follows a spike system with a roller clamp that spikes into a pressurized bag of 0.9% normal saline. Alternatively, these pressure bags can be called rapid infusion bags. For hemodynamic monitoring, such as IABP monitoring, we have to ensure that all of the pressurized fluids are always isotonic 0.9% sodium chloride. Each type of pressure bag will have some sort of dial or manometer so we can maintain adequate pressure. These are color-coded, and anything within the green area is good. Today we have two different bags that we will review. The first one's pressure is monitored via a dial, and the second one is monitored via a pop-out mechanism, both of which you can visualize that green color indicating that pressure is adequate. In the event the manometer is below adequate pressure, you can simply inflate the pressure bag until there is adequate pressure in the green area. The pressure bag is equipped with a bulb similar to a blood pressure cuff bulb. It has a three-way stopcock on it as well. You will then use the bulb to squeeze the adequate amount of pressure in until the dial reads in the green. Once the pressure is adequate, you will turn the stopcock into the up position to maintain the pressure. In the event that the pressure indicator is ever in the red area, you will do just the opposite and turn the stopcock down towards the bulb, releasing excess air. In the event too much air is released and the dial returns to the yellow, you will repeat the first process of turning the stopcock off to the air and inflating the appropriate amount of air into the pressure bag. Moving back down the line to the transducer, we're going to talk about transducer placement. This placement needs to be at the phlebostatic axis. Using the phlebostatic axis, we can approximate the anatomical point where the right atrium is. Monitoring with the transducer properly placed in this area will most accurately help us to assess the patient's hemodynamic status. The phlebostatic axis can be found at the fourth intercostal space at the mid-anterior posterior diameter of the chest wall, as seen here. Now let's review a way that we can obtain blood specimens from the patient's arterial access. Sometimes this can save the patient a needle stick, and it is very convenient. The supplies that you need for this procedure will vary based on the facility and the type of arterial line setup that you have. Today, I will show you two different types of specimen collection with two different types of arterial lines. Beginning with the arterial line we have already reviewed, we will use the stopcock closest to the patient's access site. If we've been using the line to monitor, the stopcock will be off to the air. Uncap the port and cleanse it with the appropriate solution. Since the line is primed with saline all the way down to the access site, we will need to waste the first little bit of blood. Attach an empty, sterile 10 cc syringe and then turn the stopcock towards the line, meaning away from the patient. You will then pull back the required amount of waste. In this case, I'm removing 10 milliliters. That ensures that none of the inline saline is in our blood specimen. In between each of these steps, it is imperative to return the stopcock back to the off-to-air position. This will prevent any arterial blood from pulsating out that open port. Once the waste is discarded appropriately, you may then attach the tube transfer device directly to that open port. Today we're going to be using a slip tip connector. You will remove the cap from the tube transfer device and slide it directly in the open port. You will then turn your stopcock back off to the line, away from the patient. You will then use the appropriate order of draw to pop your tubes onto the transfer device. These tubes are already designed to self-fill based on a negative vacuum. When we are obtaining from an arterial line, often these tubes will fill much faster than from a vein. Note that our arterial lines are simulated, so the blood fill is slower. Using your facility guidelines, invert your tubes appropriately, label at the bedside, and prepare to send them to the lab. Before disconnecting the tube transfer device, make sure and turn your stopcock back off to the air. Disconnect the transfer device, and then work your way up the line, and you will use the squeeze trigger inline flush. Simply squeeze in on the two tabs, and this will allow saline from your pressure bag to flow down the arterial line to clean the line. You will flush until the line is completely clear. If you look closely, you can see that the designated off-to-air part of the stopcock is now filled with blood. It is imperative that we flush this blood out, as stagnant blood causes infection and can also occlude the line with a clot. Turn the stopcock towards the access site, which will block off any backflow of arterial blood. This opens up the lumen between the port for air and the line. Place a clean gauze just under the opening of the port and go back up to the transducer and flush the line again. This will utilize flush to push through that port and clean it appropriately. Replace the cap and then turn the stopcock back off to the air to resume hemodynamic monitoring. Now let's look at an alternative arterial line access site with a different type of transducer set, wasting procedure, and a different flushing mechanism. Here you can see our access site in the radial artery. It is splinted with a black brace. Please ignore the two red tubes, as that helps the art line to function as realistically as possible. You will see that above the access site, again marked by the X, we see a three-way stopcock. Just above the three-way stopcock, there is an additional rubber stopper access site for specimen collection. This has to be accessed with a needle, therefore the stopcock method is safer. Additionally, you will note that this device here was not on the original art line that we reviewed. This is called a safety fluid reservoir. These devices come in all shapes and sizes depending on the manufacturer of the line setup. These devices are designed so we can do an inline waste, thus decreasing the amount of accesses in this sterile fluid path line. The safety fluid reservoir of this line has two covered tabs. You will squeeze in on those tabs. You will pull this back until the reservoir will no longer pull back any further. You will then turn the white lever to turn the lumen off to the safety fluid reservoir, keeping the waste above the level of specimen collection. Just like with the first arterial line, we will utilize the stopcock's extra port to access our blood specimen. Keeping the lever pointed off to the air, we'll start by cleaning our port. Then we will attach the Luer connector tube transfer device for specimen collection. We will then turn the stopcock off to the line setup and away from the access site. Pop on your tubes using the respective order of draw, inverting them as appropriate like before. Once all tubes are collected, you may turn the stopcock back off to the air. You will then disconnect your tube transfer device and prepare to flush the line. First, we must give back our waste. In reverse order from pulling back the waste, we will turn the two-way lever back to its neutral position, opening the lumen of the line. Then, pressing in on the two tabs, we will gently give back the waste that is collected in the line. Once the waste has been given, we will use the transducer set in order to flush the line, very much like before. With this transducer, you will note a blue elastic device called a pigtail. We will pull on that to activate our flush. Again, we will flush the line until all blood is cleared and the tubing is completely transparent. Again, we will still have blood collected in the port designated for air on the lower stopcock. Now I will show you an additional way in order to clean out that port. Attach an empty sterile 10 milliliter syringe to the port designated for air on the stopcock. Turn the stopcock off to the patient towards the access site. Then simultaneously pull on the pigtail engaging the flush and gently pull back on the plunger of the syringe. This pulls the flush from the line into the syringe, including the blood from the port. Once the port is completely clean, disconnect your syringe and turn the stopcock back off to the air. You should be able to resume hemodynamic monitoring at this point. Now that we understand the basic setup of arterial lines and their management, let's talk about site assessment. When we assess the site, which should be the very first thing you assess upon entering the room and the very last thing you assess upon leaving the room, your findings should include no visible bleeding, the site should be soft to palpation with no pain, no signs of hematoma, which can include a hard, painful knot under the skin, with or without bruising. We want to ensure the patient's vital signs are stable. Lastly, we will make sure the system is functioning appropriately. All stopcocks are off in the correct position, there is adequate pressure on the pressure bag, and we have 0.9% normal saline within our pressure bag. We won't go into too much detail about system functionality and waveform readings until you have covered that process in lecture.